Thanks very much. Well, in 5 minutes, I'm going to convince you of the role of embolization. These are my conflicts, none of which are relevant to this talk. Everybody in this room knows that varicocele is varicose veins in the scrotum and the pampiniform plexus. They traditionally been said to cause infertility, pain, and atrophy, but there's a bit of a testicular renaissance going on at present, and there are some who would convince you that they're associated with low testosterone, recurrent miscarriage, and BPH as well. And there's some very interesting research going on there, including at our own institution. A reminder that you don't need to intervene. In fact, you can get actually statistically significant improvements in sperm by continuously cooling your junk, either by air conditioning or by refrigerated gel packs, the snowballs, and one very aptly named device. We are also jugular. This is, we cannulate the spermatic vein from above and document the reflux. And then we tend to use coils distally. In this case, we're using sodium tetradecyl sulfate. And it really doesn't matter what you use, as long as you use some type of liquid plus or minus a mechanical occlusion. There's really no prospective randomized trials of embolization versus surgery. There's really only one study with contemporary cohorts. And really, there's no statistical difference in technical success, procedure time, or recurrence. But where there is a statistically significant difference in this one paper is in complication rates favoring embolization. But really, that's not where the advantage is. The advantages of embolization are those of, in these people in the prime of their working life, of shorter recovery. And so after embolization, a mean of 1.4 days off of work compared to 5 days in the best surgical literature, and a mean of 3.6 days to full activity compared to 3 to 6 weeks. We did an Olympian immediately before the Sydney Olympics, and he competed the following week. We've done professional hockey players, and they've been right at it. In addition, we avoid the complications of surgery, which you just don't see, and usually when we're talking to patients, we just show them that picture, and the discussion is all over as to which one they might choose. The yin of gonadal vein reflux is pelvic congestion syndrome. The presentations you've all heard about. It's important to remember there are other clinical presentations of ovarian vein reflux, the most common being that they can be an incidental finding. The embolization, as you just heard, it's very similar, except that, of course, you're using much more sclerosant. In this case, this is a patient where we just use TDS and coils. In terms of clinical outcome, pretty much everybody gets between 70 and 82% reduction in pain, regardless of the embolization method used or the agent. There's really only been one prospective randomized trial versus surgery. It was hysterectomy and oophorectomy in 106 women. And embolization was statistically significantly more effective for pain relief and with a lower complication rate. Is embolization for everybody with gonadal vein reflux? Well, no, and you've heard a lot about compression syndromes already, and I just want to share our approach to this. So if we see something that looks like it might be a compression, we put a catheter in. We do this injection during quiet respiration, and you'll see we're putting not very much contrast in, and hopefully you can see that contrast is draining into the cava. And this isn't very scientific, but this is the way we would approach this patient, how we would differentiate this patient. We just go ahead and do an embolization in this patient. Whereas this patient, who in no phase of respiration drains into the cava, just preferentially drains both into the ascending lumbar system and refluxes in the gonadal system, this is not a person we would tend to embolize. We're not in the habit of putting in stents in younger patients in their renal veins, so we would send this patient off to the Mayo Clinic or somewhere similar for open transection. So in answer to the question, does embolization have a major role? Well, it does have a major role in the treatment of varicocele and pelvic congestion syndrome. The technical success and recurrent rates are at the least comparable to operative methods without the disadvantages of scar. The main advantage is the shorter recovery of young people in the prime of their working life. And what's really important if you're going to treat these patients is a knowledge of the physiologic spectrum from normal to pathologic. Thanks for your attention.